All right, so this next talk, we have a very senior team here from our partner hospital in York Region, South Lake. We've got Dr. Paul Woods, the MD, who's the president and the CEO. We're very honored to have you here. Tyler Chalk, Executive Vice President and Chief Strategy Officer. Matt Meyer, PhD Executive Director of Population Health Management at South Lake. I'm kind of jealous that you guys have these positions. And Sukumar Guganathan, is that close? Manager of Enterprise Analytics at South Lake. Is there one of you that's missing?
Matt Meyer.
It's a party game. You have to guess which one of us is Matt Meyer. So.
Okay, I'm
Matt
not
is
going to go
missing.
there.
So yeah, and yeah, I have to give credit to Matt, who really pulled this talk together and really has been an instrumental part of the whole thing. But he came down with dengue or the plague or something yesterday and was unable to attend. So we had a hurried reconfiguration last night, and we're trying to pinch hit for him. So this presentation, I'm Paul Woods. As mentioned, I'm a family doctor and president and CEO at South Lake. And so the presentation is called The Culture of Data. And in the sort of the content of the presentation, it isn't necessarily called out all the time, but one of the things that we hope you can see is that culture drives your choice of data, how you use those data in order to be able to create new numerators and new denominators to create metrics that drive decision making. But the other way around is those data actually start to change the way you think about the work you do, which is part of what culture is. And so as we, as a health system, struggle with meeting the demands and the needs of the people that we collectively serve, it really has changed in this particular experience that we've had with population avoidable days, has started to change the way we actually think about partnerships, what our role is in the system, and what actually the very nature of our work is. So first, starting with a little bit of drama, which is, according to Tyler, my penchant. I think most people who live within the province of Ontario would agree with the statement that the Ontario health system is failing. And if it may not actually be failing, it may be fair to say it's failed. If you look at its ability to provide for the care needs of the people that we serve within the funding envelope that we're given, or even some sort of hypothetical funding envelope, there is really no way that we can keep up with the tsunami of demand that we have. So it's a great time to start thinking about things in a very different way, because we have a system that's not working right now, and it's clearly not sustainable. And the answer isn't to give hospitals another $10 million. It's to really fundamentally look at the work we do and think about it in a different way. Over the past number of years, there has been an increased interest in population health management. And population health management is one of these ones. I have a quote from Dan Ariely, which Tyler's going to wince here at this point. But he was talking about big data back about 20 years ago. So I'm going to substitute the term big data, or I'm going to population health management for big data. Population health management is like teenage sex. Everyone talks about it. Nobody really knows how to do it. Everyone thinks everybody else is doing it, so everyone claims they are doing it. So there's sort of a theoretical embrace of population health management, but I would say that we're really not doing it in any kind of effective way. But I think that we've all kind of realized this is the way forward. Also, the importance of system thinking is something that we're really trying to incorporate with the legislative changes in the late 2018, 2019 associated with Ontario Health Teams and Ontario Health, the importance of thinking about ourselves as part of a system as opposed to a bunch of standalones. Again, I think it would be fair to say that everyone understands that our healthcare system is in trouble. And while we can describe what it should look like in general terms, we use adjectives like connected, they know me, immediate access, and that sort of thing. We really really don't have a clear sort of unified view of what that system actually looks like. And of course, you could ask the question, how do you know it's good if you can't measure it? So Ontario has no shortage of measures, but what we really don't have is this ability to produce a singular metric that says, we're doing really good or we're not doing really good. So if you can't measure it, you can't manage it. And I think importantly, again, with this motive towards integrated care, how do we work together towards common patient-focused goals as opposed to all the metrics I have for running a 600-bed hospital, 507-bed hospital, how primary care, long-term care, et cetera, how do you put all that together into what good looks like for the people that we serve? So going back a few years when I was a CEO at another hospital in the province, we started to get interested in developing a metric that was something that all the members of the ecosystem would say, yes, this is what the opportunity is. It would be good if we impacted that metric. And if we all worked together, we could actually do that for the betterment of the people that we serve. And we ended up resurrecting that about a year ago, and it's actually live at Southlake even as we speak.
So I'll quickly review, just to give some context, a bit about the new strategy of our organization, which we released last year. And that is to effectively evolve our organization to what we're calling a distributed health network. And that's important because we serve, for our core community hospital services, a 1,200 square kilometer catchment area, and for our regional programs, dramatically larger. But we've historically been doing that out of one facility kind of in the center, which was perhaps fit for service 30, 40 years ago, but is not now. So our vision is to, with our plan, to build a second smaller hospital and then redevelop our current campus, but then add what we're calling advanced care campuses, which are smaller community-based facilities that are going to be spread across our catchment area with the goal of pushing more acute and community-based services into those facilities to reduce the need for people to come to our current campus, which right now is the only game in town, and that leads to significant overcrowding and cost pressures, et cetera. I'll skip through this in the interest of time, but all of our work has been motivated by the quintuple aim, which we've put front and center in our strategy and is being used to evaluate new initiatives in our data and other decision making, as well as borrowing and adopting the learning health system concept from Rob Reed and others at Trillium, the Institute for Better Health, on trying to find ways to bring closer together the adoption of new ideas into delivery. In the first year, we've launched a handful of things that are enabling this vision to come to life, but we're going to focus today on the population avoidable days indicator, and I'll turn it back to I think Sukumar or Paul to get started. Paul?
I guess it's going to be me. Okay. So we have a little bit of a scenario which describes current state and then what the impact of perhaps leveraging this metric might be to change, to my first point, the thought about what is actually the work of a hospital, or in this case, Dr. Aziz. So Dr. Aziz has seen presentations about population health management. She read a few things about our hospitals in the new strategic plan that our team put together. But she feels the strain of the system in her daily work and wants to help, but she really doesn't know what to do. All she really knows how to do is what she always did. At team meetings, they review the departmental scorecard, and it's overwhelming. There are 38 indicators presented, and much to her chagrin, there's also branching logic, so you can point and click on a metric and drill down into multiple sub-metrics. And the reality is that occupancy is 135%. And 23.4% of our bed days on that particular unit are ALCs. Mean length of stay, however, ALC length of stay and readmit rate are all in line with the provincial median. And this is one of the real, thank you. This is one of the real paradoxes, is we often benchmark to a median, which is hopelessly inadequate. So the metrics say we're doing great, we've got lots of them, but her gestalt, the patients, the hospital, definitely our CFO, our COO are going, we're not really doing all of that well. So let's go on to the next one now. So Dr. Aziz goes out on rounds, and first patient she comes to is Marie, and Marie is post-op with an infection at the incision site. The plan is to use IV antibiotics, wound care, and arrangements can't be made because, it's Friday, so she can't get them at home over the weekend, so she's going to stay for 2 more days. Sean has asthma, was admitted a few weeks ago, doesn't have a primary care doc, and couldn't arrange to get his prescription, so he had another attack and ended up in the hospital, a dreaded 30-day readmit, and the team is anxious about sending him home again. Ahmed has heart failure. He had an exacerbation while cleaning his driveway. He's better now, but his driveway still isn't clear, and the team's hesitant to send him home until they're sure it's safe. May has been going through rehab post-fall and requires long-term rehab. She has multiple chronic conditions. However, the rehab unit hopes to have a bed open next week if they can move some of their ALC patients back to the community, but the team is worried about sending her home before her medications have been adjusted.
Thanks, Paul. So the population avoidable days is essentially a measure that combines 4 commonly used measures of unnecessary hospital utilizations into a single absolute value. So this iceberg model sort of shows, as the tip of the iceberg there at the top, really the events that we're seeing in terms of all of the avoidable acute care days within the system, or within a hospital in this case. The underlying factors are the different indicators that are forming this composite measure include ALCs, so really the total ALC days associated with our main campus discharges that had ALC days. The length of stay, so where the length of stay exceeds the expected length of stay at the main campus. Typical cases, 50th percentile, sort of the other component here. Ambulatory care sensitive conditions, so really the total acute days associated with ambulatory care sensitive conditions is another factor. Same cause 30-day readmissions, really the acute days associated to that form the other factor here. All sort of urgent same readmissions within 30 days for selected HIGs. So as established measures that we're all very familiar with, these are the components that make up this composite measure. The accrual logic that we devised here really starts off with ALC days being sort of a singular bucket where all ALC activity is accrued under that bucket. And then we move on to acute days associated with ambulatory care sensitive conditions as a separate independent bucket. Now, what we expect to see is that there's going to be a crossover between these days for any given patient, and so we need a methodology to be able to separate those days out. So the accrual logic really helps do that. And so in the case of readmissions, they might have an overlap with urgent 30-day readmissions, in which case they will be bucketed under the acute days for acute ambulatory care sensitive conditions bucket. In the same way, if, let's say, for cases that really do exceed the ELOS in order of that hierarchy, we would bucket them under ACSC or the 30-day readmission bucket, and lastly, the ALOS over ELOS. Now, this is a visual. This is our sort of Power BI dashboard that we developed to really quantify this for our specific hospital and really our main campus specifically. And it looks at all of these components and does give us a total composite singular value that can really help guide our efforts. So in the past fiscal year, we noticed roughly 40,000 avoidable days. And so to put that into perspective, the avoidable day bed equivalent is near 110 beds. So for a hospital of our size, which is 600 beds, that is a significant chunk of our beds that are being utilized in the way that we can avoid, essentially. So this indicator here is really, the indicator and the measure itself is, what you're seeing here is the sort of retrospective performance of our main campus itself. But really the exciting part here, and really what aligns with the subject of today's discussion, is how we're moving towards operationalizing that indicator into our integrated care center and other workflows.
Yeah, so we've done a few things in terms of educating our staff and our leaders around this new concept of a new indicator that pulls together things they've already looked at and studied over the years, and have had a number of conversations with leaders and dialogue around, okay, it's one thing to say, look, we've got this new indicator and it's going to be a new thing on the scorecard and you'll see it on the TV screen in the office and that sort of thing, but more importantly, what are we going to do about it, right? That's where we've tried to develop different initiatives that will be able to empower our teams to act on this in perhaps different ways than if they were only looking at, say, a project on ALC or a project on readmissions or a project on acute length of stay. Paul?
So, considering the experience that we actually want Dr. Aziz to have, let's go to the next slide. So Dr. Aziz proceeds to rounds. So in using our population avoidable days, extensivism, the various different components we have of our distributed health network. Marie needs antibiotics, but Dr. Aziz is confident because the extensivist clinic can get that started tomorrow. And that's something that's been live for us since April 2nd of this past year. Sean needs prescriptions filled, and those can be filled by the extensivist program. His breathing will be monitored through our acute care at home team, and he will be attached to primary care via our local IPCT, and I think we have 2 of them. We have 2 more approved, and we have 2 more in the works for the next round of approval. Ahmed, through local community partnerships, remember he couldn't get his driveway shoveled, the Integrated Care Center can arrange to have Ahmed's driveway cleared. Problem solved. He'll be connected to South Lake at home for regular visits and is educated on what concerns to look for related to his heart failure. He knows that he knows when he should go to the ED, but also knows he can reach the team at the extensivist clinic anytime as his first point of contact. And finally, when we get to May, her medications can be adjusted tomorrow in the extensivist clinic and the day after that if need be, monitored by our acute hospital at home team until a space comes up in rehab. Similar supports made available to patients in the rehab unit are going to open up spaces sooner so that the rehab isn't backed up by ALC patients. And Dr. Aziz knows that much of this can be coordinated by the team at the Integrated Care Center, which opened in July of 2025. And her contact there is always ready to help. So if we go back to our all in this together slide, population avoidable days do give us insight into the health of our local health system. So this is not about population health. This is how well are we doing as a health system. We don't have a way of measuring that right now, but we believe that we're on the path to do that through PADS. There are actionable insights that can be used at all 3 levels, the microsystem level, the sort of point of care, organizational level, the meso level, South Lake, or at the macro level, which would be our clinically integrated network, our healthcare ecosystem to drive change. And we can start to measure things like ROI. So if there's $1 million that's coming into our ecosystem, what we tend to do is we tend to keep it. The hospital keeps it. But in this world going forward, what we can look at are the population avoidable days by allocating that $1 million to the Canadian Mental Health Association going to achieve better reduction in population avoidable days than if I keep it and run some program. The objectivity of that is something that we've never had before, and it's always just tended to be get as much as I can for myself, and I don't care what Canadian Mental Health is getting, but this actually sort of forces a transparent look at how we actually allocate funds. And we can start to evaluate, is it actually working? If we think that we're going to save 5,000 population avoidable days by implementing a certain program, and it's 400, is that a good investment, or do we need to tweak it? Do we need to calibrate it, or do we need to actually stop it? So I think that's the last slide. But so with the system, unquestionably, I think we're supposed to finish with 10 minutes, so I think we're right on target. The financial challenges that the health system faces in Ontario are certainly well known, and it sort of points to that tsunami hitting the city and the hospital in that very first slide. But what this does is really talk about something more than finance, which is about the quintuple aim, and really that's what is before us, is our requirement as a hospital, as primary care providers, as long-term care providers, is all about improving the quintuple aim, and we believe this is a big step towards doing that. And so we're glad to take questions.
I have a comment and a question. So I think it's very refreshing that a hospital is actually thinking about its participation in an ecosystem for its population. I love the word population because population health is usually home care, public health, and now hospital executives are actually using this term. Do you think it would involve data sharing or sort of like reaching out to the community partners to make your vision happen? I don't think I've ever heard any CEO say, oh, if we had $1 million, we'd actually give it to a community organization rather
Don't quote
than,
me,
because
please.
we always keep the funding for ourselves, right?
So what I would say is, the original concept of Ontario Health Teams was, when you think about it back in 2018 or 2019, early in 2019, so 6 years ago, everybody thought, the hope was that by now there would be there's some sort of central adjudication of need, effectiveness, et cetera. What's the best potential impact from a global funding envelope? Which is like when an accountable care organization, and plot spoiler, I worked in accountable care organizations in the US, so if I sound a little bit different, that's why. We thought we were going to be there. I would say OHTs are a very long way from that at this point. So, what we have to do is we have to act until the world speaks in a different manner, and whether that's legislative, whether OHTs jump up to where they can manage a $2 billion funding envelope for our population. I'm fine to let someone else take it, but in the meantime, we have to sort of fix things. So I think we'll do it now because there's no one else to do it. We'll walk beside as others learn how to do it, and when it's time for us to step out, good luck, and I'm going to hand you the keys to the car, because that's the right thing to do.
I think Paul Sandor and Deepak, and Jonathan, they were talking about funding model. So the funding, we had a perverse incentive in Ontario, right? Is the funding model was funded on volumes. So why would we give up volumes to the community if we're going to lose funding, right? So I think it's just a different way of thinking. And I had a study tour many years ago at the NHS. You were mentioning the NHS in one of your slides. And they're very much like an ecosystem, right? They're working together with their primary care. The National Trust is sort of in the middle. Do you think Ontario will get there someday?
I hope so. And we're having conversations. I think the challenge is, we have a $95 billion a year health system, which makes it one of the largest sort of single jurisdictions in the world. And if you look at what Nirvana is, there's no question to me that that's a risk-adjusted total cost of care global funding envelope. That's really easy for me to say, and I could make the case for it in under 3 minutes. I think everybody would go, yeah, that's true. The challenge is how do you get from there to here? Because there are programs that are funded that you would suddenly stop funding. And so the real hot topic, and I'm having a conversation, it's Thursday or something like that, with the ministry about how do you start to craft transition models? Because the funding model does not work in this province, and it entrenches behavior that keeps forcing us back to what we always did. And it's crack or it's heroin. We keep doing it because that's what we always did, and it feels good, and it feels bad if we stop. But we have to take that brave step. And courage, not for the records, is not necessarily the long suit of a publicly funded politically driven system, is to have the courage to actually do something radically different. But please do.
Are there any other questions? You have a question, Deepak.
So thank you and congratulations. I absolutely love the population avoidable days model. I think it's brilliant, and so really resonated, and the narrative and the story with it. I think you guys have done a phenomenal job, so thank you so much for sharing that today. I'm gonna apologize and ask a bit of a detailed question. When we create indicators that are sort of somewhat aggregated, are you finding, or are you, as you sort of go down this journey, are you seeing that there's any sort of challenges coming up from a trust or a buy-in perspective in terms of, well, if I shift the ALC date and when I assign somebody ALC, and that's going to hit me on the length of stay, and vice versa. Just a bit curious around if you're running into any buy-in constraints.
I think we're still relatively early days in terms of rolling it out, so we've kind of socialized it with our leaders. We're reporting on it internally now, but as part of our planning for a series of new initiatives for next fiscal, we're looking to how we actually operationalize every day some of the access and flow initiatives. So one we don't have time to go into today, but came out of the NHS called Red to Green, which is a real revolutionary way to kind of turn access and flow on its head. So I would encourage people to look that up. But we're trying to enable this indicator, some of the tactical programs like Red to Green and our integrated care center, which is what we've called our internal flow command center, to enable the change. I don't think we've had pushback in terms of combining them or kind of any sort of shifting from bucket to bucket. We've always tried to reinforce starting with the why versus here's a new indicator, we've added these things together, it's what we're reporting on now, because we're not saying obviously ALC in and of itself is no longer important, or readmissions is no longer a problem. We're just trying to visualize and get the mindset shift on holy fill in the blank. We've got 110 beds right now that are for people that are full 365 days a year, that are being staffed in the highest cost care setting in the health system for people that don't need to be there, and it's not helping them at all. So we try to position it that way, and so far so good.
Well, and going back to the culture word, when we first socialized this with our directors, there were a few people who were sort of tepidly in favor of it, and I would say the strongest responses that we got, because we did one of those, whatever you call it, polls, is this isn't my problem. And so for me, that was a real litmus test for the health system, because if the quintuple aim is all of our problem, if we're all trying to do that, then of course it's our problem. And even if we as a hospital can't impact ambulatory care sensitive conditions, or we can't impact ALCs, we start to think about programs that we can partner with others or advocate to actually do that. So I think it's making it all of our jobs to improve the health of the population as outlined by the quintuple aim. So it's a huge cultural driver, but there was definitely pushback when we did that the first time.
That's great. Thank you very much.
You're welcome.
Thank you.
Thank you.